You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In today's episode, we're diving into one of the most critical and indeed most often understood areas of pre-hospital care, that of defibrillation and the future of cardiac arrest management. So we're all familiar with the mantra of shock early, but how much of what we believe about defibrillation is grounded in evidence versus how much is a myth carried forward from either tradition or training? So to help us separate fact from fiction, I'm joined by Michael Heller. Michael is the Chief Commercial and Strategy Officer for Corpuls, a company at the forefront of resuscitation technology. So Michael brings a unique perspective, not just from the engineering and innovation side, but also from working closely with clinicians across the world to understand what really makes a difference at the roadside. So in this conversation, we're really going to explore the enduring myths of defibrillation. We're also going to look at the technologies shaping the next generation of devices and how data, AI, and post-cardiac arrest strategies could redefine survival over the next 5 years. So this conversation really is about challenging assumptions, sharpening our practice, and looking ahead to what's possible in day-to-day practice. Welcome to the podcast, Michael.
Thank you very much for having me.
You really do have a unique perspective. You're speaking to clinicians really around the world. What are some of the biggest myths and or misconceptions that you bump up against or encounter, Michael, around defibrillation in the pre-hospital setting?
That's actually an excellent question. And it's a question that comes up more and more often, I'd say, in the last 6 to 12 months in comparison to the years prior. I think there's more and more interest again in defibrillation. And one of the analogies that I currently use often is that people believe a 200 joule shock is like a generic drug. And I totally understand that during med school and so on, there's a whole lot of things people have to learn. And some of the physics classes are probably learned quickly and used quickly in a test and then might be stored somewhere further back in the brain. But there's actually a massive difference. And whilst you can easily substitute one drug with another if it has the same ingredient, a defibrillator is not a generic box. If it says 200 joules on it, there's always the same coming out of it. So there's a lot more around it. And I don't want to bore your audience with like volts and amps and impedance and ohm and so on. So it's not a physics class, but I think that's one of you call it a misconception, is that a 200 joule shock is a 200 joule shock.
Yeah, indeed. No, indeed. And actually, like you said, the physics absolutely matters to reduce impedance, but also, like you said, to improve the efficacy and efficiency of that shock. But there's another myth which seems to be promulgated or indeed banded around sometimes, is that defibrillation works or always works if it's done quickly enough. Could I get you to speak to how we sort of better communicate the reality? For sure, early defibrillation when it's needed, but could I get you to really kind of debunk the myth of the fact it always works if it's done quickly enough?
I mean, defibrillation works. We've all seen this. If we come to a patient and we see coarse VF and we put the pads on, ideally we put them in the right position, and then we analyze the rhythm and we charge and we shock. And then there was defibrillation, VFib first, and then there is no longer. And that is what defibrillation is. We have ventricular fibrillation to begin with, and when it was successful, it's gone. It doesn't mean defibrillation was successful like it's in a movie that the patient wakes up and thanks us for us showing up. I mean, we all know that that's definitely not what's going to happen, and it's not the expectation. But we have to see what its role is in the whole cardiac arrest. So if we have a patient in VFib and we place our pads and we charge and we shock and we no longer have VFib, what we need for that is VFib. And then you just mentioned shocking early. I mean, obviously, if it's a witness arrest and if the patient goes down in the foyer of a bank and basically in line of sight of an AED and there's a trained first responder and they put that one on, that defib probably has a lot of an easier job to get the job done versus you arrive in your ambulance and there's probably been a little bit of chest compression in the meantime, but maybe not as high quality, and you arrive and you might not even have VFib anymore. You have a rather fine VFib, and you have to reestablish circulation during your chest compressions, probably adding epi or whatever you do in your SOP and so on. So the more tricky it gets, the more powerful your tool needs to be. You can probably compare it a little bit to a power drill. If you have a drywall at home and you want to hang a picture frame, the power drill that is affordable and at your local Home Depot store probably will do the job. But if the heavier crew comes on later and has to drill a bigger hole into a massive steel concrete wall, they probably need a bit of a more powerful tool. And this is what an ALS defibrillator is. They use a higher voltage to overcome the transthoracic impedance and to deliver more current, so more amps. So now we're slightly slipping into the physics class, but I sometimes make that comparison or want to emphasize that joule's not the way to measure it. Like it's the easy power drill probably has somewhere on a number that is comparable to the professional tool, and it's this probably the same issue with defibrillators, but a high quality ALS defibrillator delivers more current at a higher voltage than your probably easy accessible and also for a good reason more affordable AED.
So let's look at the myth of stack shocks. Well, it's not necessarily a myth, it's the lineage and history of stack shocks. It used to be the way that you'd shock the myocardium 3 times and, just absolutely, stun the heart. Could I get you to sort of speak to why that might not be the most efficient way and why they, like you say, the algorithm and indeed the protocols changed?
Yeah, I think it was the SOP that was taught when I started in ambulance. When I started first was in 2002, and we did 15 compressions and 3 shocks, and gave a whole lot of epi, like through an endotracheal tube and so on. And that has changed a little bit. And now we know the way defibrillation works is to engage the heart muscle cells, to have them in a refractory phase at the very same time, so that we terminate VFib and give the internal pacemaker, sinus node, AV node, and so on a chance to take over, to not just have the termination of fibrillation as if we want to give it a scientific term, primary outcome, but also to allow for a return of organized rhythm. And therefore, we need this engagement at the same time, refractory time at the same time, and then the body to be in the state to take back over. And for this, we need one high current shock, ideally over a fixed time, to get this engagement of the heart muscle cells, which in our regular resuscitation scenario, arrest and a little bit of maybe bystander CPR, ALS arrives 5, 6, 8, 10 minutes after. That's that one shock. And for this reason, we at this stage don't even know what's the cause of cardiac arrest. If we were with a patient and something was to happen and that patient has perfusion to begin with and goes into VF, let's say because of a procedure inside a hospital that's being done, then there's no need to not try or to establish perfusion first, because that patient had good perfusion up until the second we've seen the rhythm change to VF. So then the only treatment we can basically apply is defibrillation. And then I think it definitely has its place to try it a second and a third time. For me personally, and I don't want to see this as a recommendation of Corpuls as the manufacturer, but for me personally, that would always be the highest current, because we select energy on a defibrillator, the highest energy setting that device has, as far as it's a regulated impulse. That's important. All modern devices in the Western world have regulated impulses, but then the highest setting once, twice, maybe even a third time, because this is what is the appropriate therapy at the same time. If a third one doesn't help, I think there's no need to go for a fourth or a fifth time. But this all changes if we do not know why this patient is in cardiac arrest and doesn't have sufficient perfusion up until this moment where we are seeing the VF, if that makes sense to you.
It does absolutely make sense. No, it absolutely does. Michael, could I just pivot and look at something we've seen in the past few years is really the adage of feedback and physiological monitoring and indeed defibrillators giving us this post cardiac arrest feedback of time on chest, time of shock, and almost this chronological event where we can start to look at how we get better and how we improve our cardiac arrest management. Could I get you to really speak to really how what your thoughts on embedding this technology has done to cardiac arrest management?
Probably a bit of a follow-on to what we've just discussed before with that question is it doesn't help if we do the world's best defibrillation, but our chest compression is no good. Or if we do wicked chest compression and we're great at shocking, but we're completely neglecting the airway. So we need to take care of everything that's not working fine. And in a cardiac arrest, there's basically nothing happening by the patient physiologically. So we have to make sure that we are ventilating the patient, that we are providing oxygen and getting rid of the carbon dioxide. We have to establish perfusion by compressing the chest, whether we do this manually or mechanically, in which spot we're doing this, at which rate, but we have to provide sufficient perfusion for the body, including the brain. And then when we are in this VF, the patient or the body most likely won't gonna come out of it, and it's not a sustainable state, and then we have to defibrillate. So at the end, to look at how we've done, what we've provided to the patient, in which quality, and debrief, I think that's something that professional teams should do. I've never been an F1 driver and I've never been a mechanic, but if you see how they perform in their pit crew approaches and so on, I'm pretty sure they A, train, and then they B, debrief on how they did and how they can improve. And I think if we look at ourselves as ALS crew or as team members involved in a cardiac arrest, starting with a first responder or a bystander, if we debrief on how we did, if we expect to do this again in our working life or career, then it's good to look at where we've done well and where there's probably room to improve.
So just looking at, I think anyone that's done cross-sport care for a number of years understands it's not as much, it is absolutely important what you do on scene, but the bystander CPR and indeed the early call for help is equally as important. And could I get you to really just unpack for us really, the oversimplification of cardiac arrest management, and almost the public messaging just the time on chest or just starting the cardiac massage or the CPR is equally as important as getting a defibrillator onto a patient and almost making sure that the public have got CPR as top of mind before getting a defibrillator on the patient.
I mean, I totally understand that we need guidelines for CPR that are as easy to teach as somehow possible. We all know when we're talking to colleagues and they say like, oh, we had a wicked resus case recently, and then they start in like a 43-year-old male, and when we arrived there was like ongoing chest compression by the neighbor who's like a volunteer firefighter or something like this. It's usually how they start. Like those cases, healthy enough patient to begin with, doing some kind of exercise or mowing the lawns, and the neighbor saw it and then started cardiac arrest. And we know like this story has potential. So again, we need this system to save a life. And for a person who doesn't work in ALS care, it probably has to be simple enough with 100 to 120, 5 to 6 centimeters. And we all know like that they're been given options for like either go to the rhythm of staying alive or highway to hell or whatever their preference is. But I think that makes sense. And if somebody was to teach me something that I probably do once a year or once every 10 years, I'd probably want that simple SOP that I can remember, and especially when it's a stressful situation. To me, this all changes a little bit if people arrive who have undergone years of training, including physiology, and treat patients as a career, whether this is a paramedic or nurse. EMS or emergency physicians. And this is where you said this at the beginning. I have the pleasure of working with people around the world. And I think this just means for people who do ALS care, including cardiac arrest, for a career, we can probably burden them with a little bit more. They're probably able to look at the patient and identifying, I'm treating a 30-year-old athlete of like 60, 70 kilos, or I'm treating an 85-year-old, 140 kilos with maybe several comorbidities. And this is where this opens up, or should open up, probably a little bit more in thinking, okay, what's the cause here? What am I doing? Is it really the same compression depth for the 60 or 150 kilo patient? Is it always the same rate? What am I seeing here? What am I trying to do? And this is when I think of, one thing is defibrillation, but the other thing then is chest compression, or using a mechanical chest compression device. If you expect it to do CPR more often, you might have a tool for it. How do you set it up? What compression depth do you use? What frequency do we use? What do we prioritize? And do we maybe, if we are in a fortunate system that probably has double dispatch, has people with higher education showing up as a rendezvous system or something like this, do we maybe use modern technology like ultrasound or TOE probe to optimize the compression point where we believe we will get more cardiac output if we deviate slightly from where the guideline says we should compress, if we deviate slightly from the compression depth that we are providing, if we're maybe extending the chest compression time frame and not pausing for an analysis because we think like, okay, we are in PEA, and what we need to do first here is to establish the perfusion. We may need help of a vasopressor or other tools that we are familiar with, that the crew uses on their regular basis, and then go towards a milestone if we then arrive and we have a PEA or a systolic patient with no perfusion, and get to a point where we can actually say like, yeah, we're now seeing that we're doing something, we're ventilating, colors changing, we might even get a pulse ox rating if we're doing good compressions and so on. And then we get to a state where the patient goes into VF and VF becomes more and more coarse, and that's then the time when we pause and analyze and shock.
So, Michael, could I slightly pivot and just really look at some of the emerging technologies that you guys are working on? Because it's quite an exciting time, actually, both for Corpuls and in the industry, around really real-time physiological feedback in guiding not just when, but how we shock. Could I get you to really just maybe unpack some of the innovations that you're working on right now as to really guide us to when and indeed how the optimal shock is delivered?
We have the fortunate situation that we can also trial those things together with partners in an animal lab. So where you have more sensor data than you would have with a real patient out in the field. So if in an animal lab we have an ultrasound flow probe around a carotid artery, that's obviously not possible in real patients. But even if we're looking at data where post-mortem we take out tissue probes and look at colors they're called microspheres, so that we can determine how perfusion was at certain stage of a standardized protocol in an animal lab. But what I find quite intriguing is how much correlation we there see with end-tidal CO2. So I think there's a tool we have at hand that we can use, and then also with good quality pulse oximetry, if we place that, and that's something that we are currently seeing with some very progressive services. We have a sensor available now that measures the pulse oximetry inside the ear canal. I think you may have seen this one at one of the recent Australian conventions. It's just been TGA cleared a couple of months ago. So it's a very, very new technology, and the majority of the listeners will not have had a chance yet to see this or try this in patients. But if we're measuring, for example, pulse oximetry centrally inside the ear canal close to the brain, and we're seeing like this is actually coming up, this is definitely something. I think we had a bit higher hopes for near-infrared spectrometry in the past, which we thought, I think a lot of people in the industry, including me 10 years, were basing a bit more hope on that. It's I think in the animal lab, it may help us a little bit, but there we can get a baseline with our regular patients. If we stick with those examples that we arrive 8 minutes after and we don't quite know what has happened before, in an out-of-hospital scenario, we don't have a baseline on that patient, and then all we have is a bit of a trend. And it's also a tool that we're not quite familiar with. I think it might be different if we're talking to heart surgeons or cardiologists who use that in their daily field of work, and then it's probably their tool to go with to predict whether they're doing good resuscitation efforts, or whether what they're doing is going into the right direction. So I think there's a bit of modern technology, but also technology that we've been carrying with us for quite some time. And if we're looking into end-tidal CO2 or into capnography, it's one more of those topics. There's capnography and capnography. So obviously the very old ones where we just see color is probably not quite the right tool, if available. From my perspective on technology that's out there, if people have access to mainstream capnography, measuring close to the patient, if they're using an endotracheal tube and having a mainstream capnography sensor right at the endotracheal tube, that's a tool that definitely gives a whole lot of insight in what's happening within the patient, whether there's actually carbon dioxide being produced, and then there's obviously something happening.
Absolutely. And I think what we'll do in the show notes is put links to the inner ear waveform technology that you guys have really started to lead the way on, because like you said, really from an SpO2 and a oxygen saturation perspective, getting that central reading is absolutely fascinating for efficacy and efficiency of both intra-arrest and post-arrest data. So we'll put that link in the show notes. Actually, it's a fantastic piece of technology. Michael, just to pivot slightly and look at mechanical CPR devices and defibrillation, and I guess in a way the integration of both, so it's more seamless. Corpuls, or indeed, do you see the industry shifting towards more of a seamless transition, really, where almost maybe a mechanical CPR device has got an integral defibrillator, or indeed there is almost this remote technology which can both shock and deliver mechanical CPR? Is there any innovation in that space?
Yeah, I think it's a very good question that I would like to break down a little bit. Like we started with a conversation where we said, like, yeah, there's different things that we have to do right and have to make sure that we focus on this. One thing, if I speak to people who do emergency medicine as a career, whether it's in or out of hospital, and they've done this for a certain period of time, they're usually people who can do really good manual chest compressions. And mechanical chest compression, I think, is not out there to outperform those people. Like they can do a great job. The question is always, when we look at it more from a management level, from a scalability level, is probably something that we would use in industry, but maybe also in running an ambulance service or an in-hospital emergency unit. Do we want for this healthcare professional to be the one who is on their knees and doing chest compression, or do we want to free them up to try and understand what's actually happening here? Who's this patient? Why is this patient in our care? Do we know where this comes from? And can we see a path forward? How can we gain ROSC here? And how can we give this patient the best chance of a long-term survival? And therefore, there's one thing that is just physically draining, and that is compressing the chest. So if we can use a device that takes this out of the equation and takes over, I think we've already done a great step forward. If we then understand what this device does and what the capabilities are, that we put it into the right spot, and that we may modify. Again, I do not know where people are working, and I don't want to encourage people to to try things out in their real world, but maybe have that discussion with medical directorship or other peers and so on. So like to use clinical judgment, who's the patient, size, comorbidities, everything that we discussed earlier, and then basically taking a chest compression out of the equation. And then we know the quicker we can shock after compressing, like whether that's still while the heart is slightly filling or whether we are a second off the chest. Again, in the animal lab and everything that we are doing, I don't see a difference there. But if we establish good enough perfusion, have taken care, have had the time to think about what reversible causes do we have here. We've given it a good thought, we've implemented what we needed, and then we get good perfusion so that we get coarse enough VF, and then we can defibrillate. There should be that way forward. If we can enable people to do this with operating less devices and do that a bit more seamless, we can probably help them to implement something like this easier, especially if we're then thinking it's not always happening like in a classroom. I don't know whether you've used this in your teaching roles before, but quite often when we're coming together or when we teach ALS or something, we're in a big classroom and tell people like, how often has it been like this when you arrived at scene? It's usually more confined. It's like that bathroom analogy that we use. I'm sure there's various things that happen in hospital, like on a hallway or in a room. And then also we have patients that have to be transported for definitive care. And I mean, you work with HEMS closely. There's not a whole lot of space in the back of a helicopter. It's getting better over the last 10, 15 years. I remember they were way smaller when I started. And when you now go into the back of a nice modern helicopter, there's actually a whole lot of space to look after a patient, but still it's confined. An ambulance would be moving. The roads are never perfect. Nowhere in the world do I meet paramedics that say like, oh, our roads here are perfect. Everybody just thinks their roads are the worst. So if we can automize things, if we can help people to only operate one device and maybe synchronize their mechanical chest compression device to their defibrillator, run the resuscitation from there, have a good overview of the vitals that they're getting, and then if they're considering that this is a pulmonary embolism and they decide they need to go into hospital for treatment, they need to be able to have that patient in radiology, have a CT or whatever available, and then I think this is also where this can be of tremendous help.
So just looking ahead, Michael, we're starting to see baselines of data and data analytics shaping decision makings. Could I get you to speak to really how you see AI and data analytics, particularly around defibrillation timing and rhythm recognition, shaping cardiac arrest management, really?
Yeah, that's for me, this is going towards like a patient-centered treatment approach. We were talking before that we need the guidelines that can be taught in a supermarket parking lot or something, or to volunteers over an hour or two, and that healthcare professionals might be able to deviate from those very basic algorithms. If we were able to transmit the data that we get from there to a greater source of knowledge, and if that knowledge actually knew what happened in the past, like if this patient was given 3 times epi in the first 5 minutes, the outcome was that much better or worse. There's a whole lot of studies where we see they end up being equal in the end, but there's people who run those studies, and if you talk to them at conferences, they've really seen something. And then we're talking about responders and non-responders, and how can one emergency physician, one paramedic, one nurse, you don't see 1,000 or 10,000 patients, but if we look at the capability of large data models, if a large data model has the data sets for 1,000, 10,000, 100,000 resuscitations and knows, okay, this was a patient in that environment at home or in the hospital, and that patient's on such and such medication and so on. And then after doing this, that happened. So what was the best way forward? Was it 10 minutes, sole chest compressions uninterrupted with continuous ventilation, and then just do nothing but, and then defibrillate and measure perfusion in a certain way. And as long as this is good, you will get this patient back, and they will walk out of a hospital CPC 1 or 2. And then that might be different with a different patient, different demographic, different background, different comorbidities, where it says like, look, if you need to get to this perfusion, if you can't get there, then there's no real way forward. I mean, there's also this question about in some countries, there's a lot more patients who are being transported with all the resuscitation attempts to a hospital. And when you then talk to people, they actually already know that there was no real goal. It was just basically moving this decision. That could also be a help for the whole system, like to maybe determine, so like, yeah, we've looked at everything. We've run it through like our data set, and there's not really a viable option here. There's not a whole lot we can do. I mean, again, it might also go back to the reason why a patient is in cardiac arrest. Like if there is like a massive occlusion in one of the main stems and the of the coronary arteries, and there was probably no CPR for an extended period of time. Do you really think it's the best use of a resource if you load them in the back of your helicopter and perform everything you can and then fly them for 90 minutes to a level 1 center? So I think that data will give us just more like the ability to use knowledge, experience of more cases, and then maybe focus that one down on the case at hand.
So just looking at the role of extracorporeal CPR, so EPCR, Michael, just from your perspective, you do have a unique perspective, like you were saying, really a multinational perspective on different systems and very much some innovative systems. What do you see the role of eCPR in pre-hospital care at the moment, Michael?
Yeah, eCPR has been around for quite some time, and I remember like during my time in the US and so on, there were services starting that. There's services here in Europe, Paris, for example, and so on, that were really, really quick. We in the southwest of Germany have a university hospital that has kind of a medical intervention car, specialized physicians and paramedics that respond in an area around that university hospital. And I know that, for example, in Australia, whether it's Victoria or New South Wales, and I know what London HEMS are doing and so on, those are, extremely high performing systems. And I'm sure there's a whole lot more than I just listed. If in the hands of those very, very capable people, an ECMO device is super powerful. I mean, if you can cannulate quickly, which means obviously people have to have done this several times, have to do this often enough. We can tick one of those boxes off fairly quickly that we discussed earlier. We can ensure that there's very good perfusion. Definitely that's going to be something for some lucky patients where they have an even better chance of survival. But at the same time, I have a good friend, and over the odd cold beverage in the evening of a conference, there was the joke made several times: would we probably help society more if we were to use the funds that we use for eCPR for helping people to quit smoking? And we also, if we are involved in this, and I fully respect the people, and I think it's great that people are trying to push the boundaries, but does it make sense to establish capabilities in small villages and everywhere across countries, especially like in very large countries, and then maybe people to see this as the silver bullet and we need this to resuscitate people. I don't know whether a system would end up having a whole lot more cardiac arrest survivors if they were always trying to use this technology. I think it's definitely something where the capabilities are available, where the infrastructure is available. It shows great results, and it's kind of one of those tools in the toolbox of a professional.
So just looking a couple more questions, Michael, before we come into land. One would be really around post-cardiac arrest management. It's often can be overlooked. It's often a vital component of a cardiac arrest. Getting return of circulation. Are there any new technologies or indeed strategies which, in your perspective and thoughts, Michael, might change over the next 5 years?
Around technologies, I think that's to a certain extent exhausted. I mean, I'm not an expert on cooling, and there's people that can talk way better towards this. What I'm seeing around the world is once you have this patient and you know what you've done and you know a little bit of the background, it matters where that patient is being transported to. And that again is probably the system that people are working in. So if you have the ability to take this patient probably to like a center which receives a lot more cardiac arrest patients, again, then this patient will end up in a facility where there's most likely more experienced, slightly better trained, and maybe better equipped staff for this very case. In the same way as if somebody has like a massive sports injury and needs a knee replacement, it's not like you don't catch an Uber and go to the closest, not that you could, but like go to the closest hospital and say like, oh, like I have a knee. You'll probably research where to go best and where people do that a lot and have the latest technology available to help you cure your knee injury. And I think telemedicine can be a certain help in this case if the receiving hospital has a chance to communicate, to talk to the on-scene crew and realize like, yeah, they're giving them, if we go back to our example, like you have this ambulance or helicopter there, you say like, yeah, we're here with this 43-year-old male that we had mowing the lawns, neighbor, volunteer firefighter, witnessed the arrest, good quality bystander CPR when we arrived. And we've done this and that and like no real downtime and shocked him 3-4 times. Now I've sustained ROSC. That they say like, yeah, this is all good. Like this is not another ambulance showing up here with a patient where they're just shifting the decision of death from one facility to another. And then if they may ask a few questions, and if the crew is capable, it's like, yeah, we would have like a more regional hospital 10 minutes from here, but we're going to be 25 out. Or I don't know, like if you have a dispatch organization and say like, okay, this may happen, so we do have a helicopter in standby or something like that to shorten this transportation time. I think then it is again that system that is required to save a life, and where this facility where the patient's being transported for definitive care. I think that's definitely something. I mean, out of hospital, one can treat the cardiac arrest and there's no more cardiac arrest. We started this chat with termination of fibrillation. Like if we defibrillate, there's fibrillation to begin with, and then it's gone. There was a cardiac arrest. There's no more a cardiac arrest. But this is not the cure for the patient. They're not going to walk home. That only happens in movies where they wake up and then fall in love with their caregiver. But they need definitive care. Something led to this cardiac arrest. So they need to go to a facility where they can be diagnosed and receive that definitive care. And I think this is part of it. And there's facilities that are probably more suitable for that than others.
So just finally, Michael, this is a really difficult question because there is, to your earlier points, there is no magic bullet, there is no one solution. But if there is, in a way, just from the hierarchy of myths and indeed championing innovations, could you speak to maybe one myth which has really had the greatest impact, dispelling one myth that's had the greatest impact on cardiac arrest survival, and indeed maybe one innovation that's really championed cardiac arrest survival recently?
Obviously, we spoke about like what's all required. I'm not a ventilation expert, but if I could encourage people to think of one improvement, and that would, at the moment, from everything that I'll look at, one of the possibly largest impacts is where we actually compress the chest, because it's not physiological that we press the sternum down and blood ends up in the brain. We actually wanting to have blood come out of the heart. And if we were to consider where the heart muscle is and where we have to compress to get the maximum of cardiac output to establish that perfusion, I think that could be the single biggest step forward. If we were to open ourselves up to that possibility that every human has their heart in a slightly different position. We know that already when we interpret 12 lead ECGs, that the axle and the orientation and so on matters on how we read this. So I think that is one of the possibly single biggest effects. And around the myth, for me, it has to be the defibrillation. I think it's very, very important that we get into the minds and thoughts of healthcare professionals, of nurses, paramedics, EMTs, emergency physicians, cardiologists, that it is not Joule that defibrillates. I can lick a 9-volt battery for an hour and I gave myself a 20,000 Joule shock. This is not it. And a friend of mine correlates it to eating a Big Mac, which is, I think, equally as much. And we need to deliver current to the heart, to engage heart muscle cells, to get them into a refractory phase. And therefore, it does matter to see which kind of defibrillator we are using. There is a need for small and affordable devices to be accessible everywhere, but there is also a need for professional tools. And it's definitely will have an impact if we want to get patients to that point where they have coarse VF and we ventilate and compress them well enough, that we also shock them well enough, and that we select the right tool for this job.
Listen, absolutely. I couldn't agree more, actually. Listen, Michael, thank you for the last 45 minutes. It's great just to venture through your perspective from an international, an international perspective and indeed an empirical perspective as well. So listen, thank you so much.
Thank you, Owen. That was fantastic. Enjoyed that.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.